session. Today we'll have an OSCE on electrophysiology. We'll be having 30 questions on NCS, EMG, and evoked potentials. Be presented by myself, Nikhil, and Shivakumar, and the session will be moderated by Sruthi ma'am and Soumya ma'am. So we'll start. So each question will give you around 30 to 45 seconds per question and try to answer as much as you can. So going to the first question. So the median nerve sensory conduction studies were performed in two different ways and the results are depicted. So identify A and B. What is that square marked as C? And name one disadvantage of method A. So these are the median nerve sensory conduction studies. Next question. So name this personality. Name two of his contributions to electrophysiology and name two conditions named after him. Next question. So identify the phenomenon from this EMG study. Next question. So identify these electrodes A, B, and C, and where are A and C commonly used? Next question. Define volume conduction and give an example of a near field and far field potential. Next question. How does cold temperature affect the NCS parameters, latency, amplitude, and velocity? And what is the mechanism of these effects? Next question. So, identify the nerve stimulated from the CMAP morphology, and what is the mechanism for this characteristic morphology? There's already a clue in the picture. Next question. So, in the study, identify the waves A, B, and C, which is marked below. What happens to B in a supramaximal stimulation, and name two conditions where B is seen. Next question. Identify the grade of CTS as per the Bland system. Name another classification system, and name two electrophysiological methods for diagnosis of very mild cases of CTS. Next question. The ulnar and median conduction studies were done from the abducted digiti minimi, and the results are provided. What is the diagnosis? Mention the mechanism, and how prevalent is this condition? WR stands for wrist, BE stands for below elbow, and AF stands for the antecubital force stimulation. So these are done from the abducted digiti minimi. Next question. Identify the study. Name two clinical conditions where it is useful, and such a response is seen in, and name a condition where such a response is seen. Next question. Mention two findings in this FA study. Name a condition where such a pattern is seen. Next question. A 38-year-old lady presented with progressive weakness and fatigue. Gradually, she developed difficulty holding her head up at the end of the day. The median CMAP and RNS study at 0.2 Hz are shown below. What is the phenomenon, and name two conditions where it is seen? Next question. Name the three most important waves used for the interpretation of this study and name the site of origin of these three waves. Next question. So, identify the two abnormalities in the EMG study. And what is the classical sound description of these two abnormalities?
Next question. Interpret this RNS study. What are the frequencies used in routine and fast RNS? Other than NMJ disorders, where else do we get a decremental response? Next question. Identify the phenomenology in this video. Name other abnormal spontaneous activity which can commonly associate with this, co-occur with this, and name two conditions associated with it. Next question. In the SNAP study, mark the onset and peak latencies. Name one advantage and disadvantage of measuring each of them. Next question. Which evoked potential does the diagram represent? Mention the muscles from which this potential can be elicited. Next question. Identify the most striking abnormality in this F-wave study. Mention one condition where it is seen. Next question. A 62-year-old male presented with progressive dysarthria and dysphagia for 4 months with the loss of weight and minimal left upper limb hand grip weakness. On examination, he had a spastic dysarthria, tongue fasciculations, and left FDI wasting with brisk left upper limb DTRs. His EMG is shown below. As per the modified LS criteria of ALS, how he is classified? Name another criteria for diagnosis of ALS. Name the criteria for ALS FTD syndrome. Next question. Interpret the RR variability result. Mention the physiological basis for this test. Name any 4 other autonomic function tests. Next question. How does the stimulation in this study differ when compared to H-reflex study? What is the effect of generacic on this parameter? Next question. Name a clinical condition causing this EMG abnormality. What is the closest differential and how they are differentiated? Next question. Interpret this single fiber EMG report. What is the recording area of the ideal needle used in SFEMG? Next question. Interpret the visual evoked potential report. What is the cutoff for P100 latency in goggle and pattern VEP? What happens to P100 latency and amplitudes in children and elderly? Next question. Name the personality and his contributions to electrophysiology. Name two nerves from which this test can be elicited. Name the clinical sign described by him. Next question. Identify the study and name one of the use of it. Next question. Identify the phenomena occurring in A and B images. What happens to B in motor studies? Next question. What is the cause of this pattern in this motor nerve conduction study of the peroneal nerve? What is the additional site of stimulation to confirm one of the cause? What are the technical causes producing the same pattern during nerve conduction studies?
Yes. Fine, yes, right. आपने सुना idea almost. So first is the something like a wrist and record from the fingers, and B is the opposite, that is the autonomic study. The antinomic study, the thing is like what is marked as C is the volume conducted motor potential. So one of the disadvantage of this antinomic method is that suppose we do not have a snap, we may confuse that motor potential with the sensory action potential. So in that cases, differentiating them might be an issue. So in this question, A is the antinomic study, B is the orthotomic, C is the volume conductor motor potential. And the disadvantage is that we may differentiate if the snap is absent. So second question, name this personality and two contributions. He is Duchenne. His full name is Gillian Benjamin Amar Duchenne. Uh, he About his contributions, he was one of the first people who demonstrated that the muscle can be stimulated percutaneously, and he initially developed that instrumentation for the same. He created the first portable electrodiagnostic equipment and devised the muscle biopsy needle also. And there are so many conditions associated with them, such as DMD, then Duchenne and spinal muscular atrophy, Erb's paralysis, and Tabes dorsalis was also called Duchenne's disease, and progressive bulbar palsy was called Duchenne's paralysis. So any one of those you can write. So next question was to identify the phenomenon and name 4 conditions where it was seen. So what we see here is this characteristic waxing and waning appearance with the dive bomber characteristic sound. So this is classically myotonic discharges, and it's described as a revving engine sound or a dive bomber sound. It is characteristically seen in myotonic dystrophy, myotonic congenita, and biomyotonia. Other conditions include acid maltase deficiency, polymyositis, myotubular myopathy, and hyperkalemic periodic paralysis.
These are conditions where I can without clicking out a second.
And the drugs that can be used to reduce myotonia include mexiletine and phenytoin, both of which are available. The next question was to identify these electrodes A, B, and C, and where A and C were commonly used. So A is the ring electrode, which is commonly used for sensory nerve conduction in the digits. B is a surface electrode, which we use for a routine practice, and C is a bar electrodes, which can be useful for RNS study. So next question was to define volume conduction and give an example of near field and far field potential. So the process of an intracellular electric potential being transmitted through the extracellular tissue and fluids is known as volume conduction. And regarding near field and far field potential, near field means the source must be close to the recording electrode to record it. So that is our routine CMAP and snaps in our routine NCS. Whereas far field potential means these potentials are distributed widely. An example is our cortical waves of evoked potential studies. So next question is, how does cold temperature affect the NCS parameters and what is the mechanism? So what happens is the velocity decreases, latency is prolonged, and the amplitude increases. So the mechanism is that the cooler temperature causes the delayed inactivation of the sodium channels. So we know that this is involved in depolarization. So there is slow, this depolarization becomes prolonged, therefore resulting in slower conduction velocity. And longer channel opening time leads to larger sodium influx, leading to larger amplitude and duration of the potentials. Next question was to identify the nerve stimulated from the CMAP morphology and the mechanism of this characteristic morphology. So clue was, it was already mentioned, it was from the wrist, and there is a typical bifid appearance, and this is typical of ulnar CMAP. So when we record it, usually we record from the G1, which is made over the muscle belly, and the G2 is not over the belly. But thing is, when we are stimulating, this G2 can pick up the potentials from the surrounding muscles and all, and that can give rise to this bifid appearance, which is typically seen while recording the ulnar CMAP. So it is more of a technical issue which causes this bifid appearance in an ulnar CMAP study. Next question was to identify the waves A, B, and C, and what happens to B in supramaximal stimulation and some conditions where B is seen. So A is our motor response, B is the A wave or the axon reflex, and C is our routine F wave. So what is an axon reflex? As shown in this picture, when we do this FA study, one of those impulses can go backward and come down into that newly sprouted bud, which can result in a wave which even on successive stimulation has the same morphology, and this is called the axon reflex. Now suppose we give a supramaximal stimulation as shown in that second picture. In addition to our nerve ease testing, we also can stimulate the new sprout. So in both of those impulses can cancel out each other, and therefore with supramaximal stimulation this A reflex can be absent. So it has been classically described in GBS, and it is most often associated with reinnervation following axonal loss lesions. So the next question was to identify the grade of CTS. So the two systems we commonly use are the Padua system, which is outdated, and the Bland system, which we commonly use. So see in this table, for very severe, there should be an absent sensory parameters with a prolonged motor latency more than 6.5. As seen in this one here, we see that the left side median, the snaps are not recordable, and the wrist CMAP from the wrist is 6.9, definitely more than 6.5. So left we have a very severe, and right there is prolonged motor and sensory latencies, which makes it a moderate. So left very severe and right moderate. The other system is the Padua system. For very mild cases where we do not have this sensory prolongation, we can use this transcarpal comparison between median and ulnar. median versus radial comparison, or median segmental sensory studies. So in this next question, they said was the ulnar and medial nerves were studied from the abductor digiti minimi. So what we see here is when we stimulate the ulnar nerve on the wrist, we have a decent CMAP, but when we do it more proximally, the CMAP amplitude drops. But whereas when we study the median nerve on stimulating the median nerve at the wrist, we don't get a CMAP at all. Whereas when we're stimulating proximally, we get a smaller CMAP. And if you can observe that smaller CMAP which we got here when added to the CMAP which we got on proximal stimulation, it is all more or less equal to the CMAP which we get from the distal stimulation with the ulnar nerve. So this is called Martin-Gruber anastomosis. So as seen in this picture, from the median nerve, there might be there's an accessory supply which is going and supplying the abductor GT minimi. So when we stimulate this ulnar nerve at the wrist, we stimulate both the ulnar nerve and this accessory nerve, so we get a good CMAP. But however, when we stimulate the ulnar nerve proximally, we will not be stimulating that accessory nerve. That is why we get a drop in amplitude. Whereas if we stimulate the median nerve distally, obviously nothing is going to happen. But if we stimulate it proximally, we stimulate that accessory nerve also, which results in our CMAP. So this is Martin-Gruber anastomosis, and it is said to be seen in around 15 to 30% of the patients.
Let's go back. So this may sometimes look like conduction block from the ulnar nerve, but generally it is very mild and we don't see that it fulfilling the criteria for conduction block. But if it is very well done study, normally from wrist to elbow should only be 7.5 to 7.4 or 7.2, maybe even almost similar as the rest. Another thing is that when you stimulate median nerve and record from any of the ulnar muscles, you are not supposed to get an initial positive. This indicates straight away that the initial positive indicates that it is directly being supplied by the vagal. So initial negative.
So next question was you identify the study and to name two clinical conditions where it is useful and a condition showing this type of response. This is the SSEP study, which can be used in MS or in trauma for documenting the extent of lesion. So what we see here is a giant SSEP. The cutoff is more than 8.6 microvolt, and it is described in PME syndromes and CJD. So next question is was to mention two findings in this FA study and name a condition where such a pattern is seen. So if we look here, the amplitudes are very high. It's giant FA with persistence. So it is seen in MND and other anterior tonsil diseases. Next question: a 13-year-old with progressive weakness with fatigability, and they showed the CMAP study in the RNS. So what we see here is on stimulation on the routine CMAP study, we see that in addition to that first one, we have another peak also, and on RNS also we are seeing that same double peak. So this is characteristically called the double hump or double CMAP, which is characteristically seen in slow channel CMS, congenital myasthenia syndrome. What it is usually due to increase in acetylcholine in the junction. So it can be seen where there is excessive use of acetylcholine esterase inhibitors, and in OP poisoning, same mechanism. Next question in this Brainstem evoked response auditory, how to name the most three important waves and their origin. So the most important waves are 1, 3, and 5. 1 is from the auditory portion of the 8th cranial nerve. 3 is from the lower pons of the superior leaf, and wave 5 is from the inferior colliculus. So question 5 was to identify the two abnormalities in this following EMG study, and what is the classically described sound. We have a continuous machinery type of sound, and in between we have this popping type of sound. So it is CRD with fasciculations. So CRD is classically described as a machine sound and fasciculations as a corn popping sound.
16th question. Interpret this RNS study. Here we can see the decrement in the train of 5 stimulation and compared to the first and fourth stimulation. And again on the fifth there is an increment. It's a U-shape response. It is showing a decremental response. And slow RNS, the frequency is less than 5 Hz, usually 2 to 3 Hz, and fast is ranging from 10 to 50 Hz. Usually we use like 30 to 50 Hz. And the decremental response also seen in MND due to the immature neuromuscular junctions following the reinnervations, and also any other neurogenic process. And also in myotonic disorders, we can see these discharges. This is due to accumulation of potassium in the transverse tubules, leading to the prolonged after depolarization. Next question was the identify the phenomenology in this video. Here we can see the discharges, doublet discharges, and then triplet discharges, multiplet discharges.
This is actually myotonic. You are seeing doublet set, but you are also seeing myotonic junctions. Can we play the question? You can hear the marching sound. So that was the myotonic discharge.
Other spontaneous, abnormal spontaneous activity along with the can be seen in this spectrum is myokemia, cramps, and neuromyotonia. And the disorders associated with this myokemia discharges are radiation injury, GBS, multiple sclerosis, Fontaine tumors, hypocalcemia, and rattlesnake envenomization. In this SNAP study, onset and peak latencies you have to mark. And this is onset latency is AB, and peak latencies is the AC. AB is the onset latency, AC is the peak latency. Usually, the onset latency represents the fastest conducting fibers, and it's used to calculate the conduction velocity. But however, for many potential, especially the small ones, it is difficult to mark precisely. So there will be inter-examiner variation for this onset latency. But peak latency is easy to mark. So it is straightforward, and there is less chance of inter-examiner variation. But this peak latency represents only few population of fibers, though, so it cannot be used accurately for calculation of conduction velocity. This one, it's a SNAP study. Peak latencies. We use peak latencies because mainly for the interpretation, peak latencies are more useful because the inter-examiner variation is less. For onset latency, marking can be any of the shown arrow, so it varies and changes the report. Which evoked potential does the diagram represent? This is a vestibular evoked myogenic potentials, and the muscles from which they are recorded are sternocleidomastoid, inferior oblique, and masseter muscles. And each of these muscles have different pathways. Vestibular spinal pathways from the recording is from sternocleidomastoid called cervical vamp, and vestibulo-ocular reflex O-vamp recorded from inferior oblique. Vestibulo-masseteric reflex M-vamp from masseter. These vestibular evoked myogenic potentials are used to assess the integrity of the otolith organ and the brainstem centers. It is used in neuro-otological diseases like schwannoma, meningioma, and Meniere's disease, and assess the vestibular symptoms in MS, multiple sclerosis. The most striking abnormality in this FF study, here you can see the dispersion separated more than four different. It's called chronodispersion. This difference between.
That answer is that, have you mentioned which nerve it is, upper limb or lower? Because it is different for upper limb and lower limb. And second thing is that there are actually multiple abnormalities there. So you can write any one of them, and I think it could be eligible for an answer. So you can see that there is a repetitive FA. 3 or 4 of them are looking the same, and they are also giant FA. So if you write any of them, I think it's eligible for a correct answer.
FA chronodispersion is a measure of difference between the minimal and maximal FA response latency. And the normal values are 4 milliseconds for upper extremity and 6 milliseconds for lower extremity. Any value above this is called chronodispersion and seen in demyelinating neuropathies like AIDP and CIDP. This is a question of a 62-year-old male with progressive dysarthria and dysphagia for 4 months and also weakness of the upper limb. And you can see the UMN and LMN signs in 2 segments clinically, and also the EMG showing right genioglossus denervation potentials and left FDI denervation potentials and renervation potentials with reduced recruitment. As per the LS Corel criteria, as there are 2 segments, UMN and LMN features in 2 segments, comes under probable ALS. Presence of upper motor and lower motor neuron signs in at least 2 regions with UMN signs rostral to lower motor neuron signs. Definite ALS according to the modified LS Corel criteria is upper motor and lower motor neuron signs in 3 segments. The other criteria is Gold Coast criteria. The same clinical picture, if classified according to the Gold Coast criteria, the patient will be classified under definite ALS. Here you can see the criteria: upper and lower motor neuron involvement in 1 region or lower motor neuron involvement in at least 2 regions. And the criteria for ALS FTD is strong criteria. Interpret the RR variability. You can see the maximum and minimum ratio. Here the test is normal. The normal RR variability is more than 1.2. Any value below this is normal. And this RR variability is used to assess the parasympathetic cholinergic function. Inspiration increases and expiration decreases the heart rate. This is mediated by vagal innervation of heart. And the other autonomic function test is head-up tilt test, heart rate and blood pressure response to Valsalva, isometric hand grip test, cold pressure test, sympathetic skin response, thermoregulatory sweat test, and pseudomotor axon reflex test. Any of the can be written. How does the stimulation in this study differ from compared to the H-reflex? So this is an FF study, and how does it differ from the H-reflex in terms of stimulation? FF studies are done with supramaximal stimulation, whereas H-reflex studies are done with submaximal stimulus. And the effect of Genrasic on this F responses help in priming the anterior horn cells, so can elicit the F response where one was not present. If the patient will not have F response, you should try again with the Genrasic. But if a patient is having already FF is elicited, should not perform a Genrasic because it's paradoxically decreases the likelihood of FF response. Name a clinical condition associated with this EMG abnormality. Here we can see a rhythmic discharges sounding like a marching soldiers. Here we have seen that rhythmic discharges occurring rhythmically and sounding like marching soldiers. It is seen in can be seen in tremor, like, and also the closed differential is myokymia. And both are differentiated. If you observe the motor potential, here we can see this is the tremor and this is the myokymia. Here we can see myokymic bursts. The MUPs are firing separately.
It's a group of axons firing separately. That is myokymia. On the other hand, the other ones are voluntary. Like it's very similar to
motor neuron potentials are firing simultaneously.
The type of motor units you find will keep changing in case of tremor. The group of motor, individually spread out and see that
Here we
MVPs, they will be different type of them. Yeah, the numbers may be different, but the composition will be around about the same in case of myotonic.
Here the speed.
But unlike CRD, you can also see that CRD is of a different origin. Myokemia originates from the axon, CRD originates from the muscle fiber. CRD is exactly the same. Like one potential will be exactly similar to the next potential. Myokemia will not be like that. It will be slightly different, but the overall composition will be very similar.
Yes, interpret this SFEMG. Here you can see the SFEMG tracing. This is called jitter, and same can be seen in the study SFEMG pair 9.1, where the jitter is 130 microsecond. This jitter indicates the impaired neuromuscular junction transmission. This jitter is usually it denotes the variation between the transmission and the two adjacent muscle fibers supplied by the same axon. Usually, the jitter is very less in normal muscle, but in neuromuscular junction transmission, due to the abnormal neuromuscular junction in few junctions, there will be a variation between the adjacent fiber itself, which are supplied by the same axon. So that is called as jitter. And about the needle, recording surface area of SFEMG needle is 0.005 mm square. And the concentric needle is, when you compare with the concentric needle, concentric needle is 0.019 millimeter square.
To go back, how do you know it is abnormal jitter?
Here,
So you
9.1.
cannot say that it is very less or something. You can just say that there is a normal jitter and there's an abnormally increased jitter. Right. So how do you know this is abnormal?
Here we can see the more than 20 microseconds. Here,
Not
130.
You're right. You have to either look at the mean value, and it will be different for the type of needle used and the type of muscle. So for frontalis will be different from orbicularis oblique, will be different from extensor distal. So for this muscle, 40 is abnormal, mean is abnormal. And even if mean is normal, if more than 10% of the individual potentials are abnormal, you can also take it as an abnormal jitter. And from the appearance itself, you can see that it is spread out. You see the first one we are triggering on it, so it will all fall on the same thing. On the other hand, second one will actually show that it is all spread out.
Interpret the VEP report. What is the cutoff values for P100 latencies? Here, there was a prolonged P100 latency. Here we can see the cutoff was 110. Suggestive of likely demyelinating etiology. The normal upper limit for pattern is 110 milliseconds. And the goggle is 140 milliseconds. Here we can see the P100 latency is 130. So it's prolonged. Yeah. Here we can see the effect of age on the latencies and amplitudes. Latency is more prolonged in the patients more than 60 years. Amplitude is higher in children less than 6 years. It's probably due to the slowing of the conduction due to aging. Name him and his contributions to electrophysiology. He's Paul Hoffmann. He's a German physiologist and physician, has been referred to as a founder of modern German neurophysiology. And he has described the H-reflex. H-reflex can be elicited as commonly from tibial nerve and also from femoral nerve and median nerve. In the tibial nerve, the muscle elicited from is the gastrocsoleus muscle, and the femoral nerve, it is quadriceps muscle. Median nerve, flexor carpi radialis muscle. And we also described the Hoffmann-Tinel sign for the assessment of nerve regeneration and success after the nerve sutures.
What we call
It's called Tinel sign. Tinel sign. It's normally known as Tinel sign, but they have his contribution is also there in this. identify the study. And here we can see the stimulation of the neck at the neck seventh intercostal space recording from the recording, and test here we are testing the diaphragm contraction.
Site they have written as
Site.
neck and seventh intercostal. So what they essentially mean is that neck is the area of stimulation. That is.
And recording is the
Recording
the
starts from the seventh.
xiphoid, near the xiphoid. And phrenic nerve conduction study. It is phrenic nerve conduction study, and its applications is to look for any diaphragmatic involvement in ALS, myasthenic crisis, AIDP, and other critical illness.
Basically, it is useful to see for the demyelination. So if the latency is markedly prolonged, we usually take the cutoff as 7 in some studies or 10 in some other studies. If it is markedly prolonged, it can be considered as a demyelination. If it is very low, we consider other neurogenic axonopathic process. Myasthenic crisis is not very useful for differentiating from other others. There are many studies showing, so it's not a can go back. How do you know this is phrenic nerve conduction? Yeah, you have to see where it is stimulated. It is not possible to follow the phrenic nerve conduction study by the morphology. This is particularly notorious for having very, very different morphologies. Even if in the same phrenic nerve you do it multiple times, you may get a different morphology. It's not possible to call it by the morphology.
Identify the phenomena occurring in A and B. Here we can see this is a sensory study, distal stimulation and proximal stimulation. In distal stimulation, the recording is near, so there is no much difference in length of the conduction. So there's almost the same study will fall on the same. So there is summation of individual sensory action potentials. And in the proximal stimulation, this fast and slow fibers conduct in a different speed, so they reach the recording in a slightly different area due to dispersion, and there will be cancelled. This positive and negative will be cancelled, and will have a smaller potential amplitude. This is and the effect seen. This is in mostly in sensory studies, but in the duration of the individual motor fiber potential is much. This, because slower and faster fibers conduction is different. This is summation, and this is
a physiological temporal dispersion that you are showing.
Physiological temporal dispersion. But compared to this in motor fibers, the potential is much longer than that of single sensory fibers. So for the same amount, though there is temporal dispersion, because there is on most of the time they reach at the same time. So there is.
It's because nerves are very low amplitude, and the CMAPs are larger amplitude and slightly increased duration. And so that the phase cancellation does not occur so much. So in snaps, phase cancellation is much more. In CMAPs, not so much, because of the difference in the amplitude and duration of the individual potential.
What is the cause of this pattern in the motor nerve conduction study of phrenic? Here we can see the stimulation. This is at ankle stimulation, and this is at myofibrillar head. Here, though we are stimulating ankle, we got a smaller amplitude, but in the myofibrillar head and above fibrillar head, we got a bigger action amplitude potentials. Then, if you see such a recording, first you have to correct the technical errors, or else we can repeat the study in additional site near the posterior to the lateral malleolus. This is seen in accessory peroneal nerve, where usually this extensor digitorum brevis is supplied exclusively by deep peroneal nerve. But in few patients, if in an anatomical variation, the lateral part of the EDB is also supplied by superficial peroneal nerve, and the medial part is by deep peroneal. Here, if we stimulate in the ankle, then we get only the half of the muscle stimulated. That's why we get a lower amplitude stimulus. And if you stimulate at this junction where before the division and above the fibula, we get a full amplitude. because both the lateral and medial parts are stimulated. Again, if we have such a recording, we have to see for any technical errors, because submaximal stimulation of the peroneal nerve at the ankle site can also have a similar tracing. And also excessive stimulation of the peroneal nerve at the below fibular neck and lateral popliteal fossa sites can also cause co-stimulation of the tibial nerves, leading to the similar record.
Co-stimulation, how can you identify?
Tibial also will have tibial motor responses.
And we will not be simultaneously recording this. We will be only recording from one level to 10. Co-stimulation, how can you identify? And look for the contraction of the muscle, but by testing, you see whether the morphology of the further CMAPs are different. So this morphology should be very similar to this one. So if suddenly there's a change in morphology, it is because some other nerve is also contributing to that potential. So essentially here the numbers you see, you can see that. Can you please go there? The numbers you see, you can see that the amplitude is 5.7 at ankle, 8.1 at below fibular head, and 7.4 above. That is not usually seen. If that is there, it indicates that there's either an improper technique or an accessory peroneal. Prepared questions. I think we made the finally are ready for the exam. Stop.
Thank you for patient listening. We are stopping the session. Thank you.